Welcome to part 2 of the bioequipment talk. In this section, we'll discuss electrosurgery and tourniquet equipment use. So what is the difference between electrocautery, electrosurgery, and diathermy? The terms are all used interchangeably, but they do have specific meanings. Diathermy is Greek for to give heat, and this can be done through a multitude of methods including radio waves, sound waves, electricity, radiation, and so forth. But in all cases, some type of transmitted energy is converted to thermal energy. Physiotherapists often use sonic energy on scar or muscle tissue to heat them up and allow for increased blood flow and stretching. Electrocautery also comes from Greek and means to burn. Finally, there is electrosurgery, which uses an electric current to provide thermal energy. So how does electrosurgery work? Well, it all began with Cushing, who was a neurosurgeon at Johns Hopkins. Cushing had a problem, especially in neurosurgery, because there was a tremendous amount of bleeding when operating on the brain. Bovey, on the other hand, was a biophysicist at Harvard. Specifically, he was a plant biophysiologist. He recognized that a AC current at specific frequencies above 150 kHz could pass through biologic tissue without causing any reaction. Therefore, no nerve or muscle contractions or stimulations. More importantly, he realized that when you make a patient part of an electric circuit, there are thousands of electrons flowing through the circuit. The only problem is at the cautery tip, where all these electrons are becoming concentrated and building up at a huge amount of resistance. Eventually, when released, these electrons dissipate as a big burst of thermal energy, heating the surrounding area by over 1,000 Celsius. Bovey sold his invention for $1, and after a few years, they were able to get a functional human electrocircuit that coagulates bleeding. Modern-day electrocircuits have a grounding pad, and this ensures that the circuit does not travel in alternative pathways. Previously, surgeons used to be electrocuted and fires would be set off just by the anesthetic gases. Modern-day generators are much safer and require grounding of the electrocircuit. The key element here is tissue resistance. Electrons will always move to areas of lower resistance, which is perfect for working around areas like the brain because blood vessels have a much lower resistance than brain tissue. So those electrons will jump or arc and cauterize those blood vessels before traveling to the brain tissue. This allows for safer dissection by providing coagulation around vascular areas. There are two ways by which cautery dissects. The first is vaporization and the second is by coagulation. With vaporization, the temperature reaches over 100 Celsius, and since cells in cellular matrix is around 80% water, it dehydrates and desiccates the area into tiny bursts. Coagulation, on the other hand, occurs at much lower temperatures, around 60 Celsius. This allows for denaturation of proteins and tissues so that they shrivel up but don't necessarily vaporize. When dealing with blood vessels, denaturation is perfect for creating ligation. Take a look at the upper left-hand picture and you can see the difference between cut and coagulation. Cut settings use a much lower voltage, but it is on 100% of the time, and this can be seen by the graph on the right side, where it is constantly on. But because pure cut does not control bleeding, most surgeons tend to use blended cut, where there are some silent periods that allow for denaturation and therefore coagulation. Coagulation, on the other hand, has a much higher voltage, but it is only on for 5% of the time. Therefore, when you are holding the electrocautery tip onto the tissue and pressing it for a whole minute or 60 seconds, the actual electrocircuit has only been on for about 2 seconds during the coagulation phase. A commonly asked question is about the power settings or watts. There is no clear answer because regardless of what the tissue resistance is, holding the cautery on it for long enough periods will overcome the resistance and allow for dissection. Even scar tissue, which has the highest resistance, can be cut at 10 watts of power if held there long enough. Therefore, the desired cautery effect is not only dependent on the power settings, but also on the tissue resistance, the generator mode, meaning cut or coagulation, and the duration of the electrode contact. As a general rule, coagulation is placed between 10 to 40 watts, while vaporization is between 30 to 50 watts, and carbonization is 40 to 60 watts. The upper left chart of maximum power output settings is for the Valley Lab electrosurgical generators, but differ on the type of generator being used. So what's the difference between monopolar and bipolar cautery? Monopolar cautery incorporates the patient as part of an electric circuit. As a result, a larger volume of tissue is involved, with more smoke production and concerns with its use around implants. Likewise, it's difficult to use in wet fields. Bipolar cautery, on the other hand, uses the electrode tips as the circuit, and so only a very specific volume of tissue is affected with virtually no smoke production, and the ability to use them within wet fields. Vessels up to 7 millimeters in size can be ligated with bipolar cautery. So what are the most common complications of electrocautery? First is the risk of coupling, which can be due to direct or capacitive coupling. Direct coupling is when an adjacent instrument conducts current. The classic example is holding a metallic suction tip and burning the superficial skin edge. Capacitive conduction is when the circuit is directed inadvertently through a material with less resistance due to insulation failure. This can arise from the Mayo stand or an IV pole touching the patient. The second problem arises from burns and fires. The majority of burns occur at the grounding pad. However, fires and burns can also start from bowel or anesthetic gas, as well as from the alcohol preparation solution, which can often be invisible. Other reported cases have involved metal capacitive coupling, as previously mentioned, from Mayo stands or IV poles causing burns. Tattoos, jewelry, and implants lend a special consideration. Try to remove all jewelry in regards to implants. Try to place the grounding pad in a position that ensures the electrocircuit is not in the implant's pathway. Also, be aware of implants like cochlear implants or pacemakers. Finally, in regards to tattoos, they may contain traces of metals, especially red color in tattoos. Never place a grounding pad on a tattoo site if there are other options. If there are no options, then consider a grounding table pad instead of a electrocircuit pad. Finally, in terms of the smoke hazard, there are no specific guidelines, but the National Institute of Occupational Health has concluded that it does contain toxic gases worse than smoking and has a potential to carry aerosolized materials and viruses. So what are the rules regarding grounding pads? Over 75% of all patient burns are at the site of the grounding pad. Remember that the pad is there to ensure the current is being removed from the patient in a safe manner. It is basically the return electrode. Modern pads have two return surfaces so that it is continuously monitored and will switch off if there is any abnormalities. The reason that the cautery pad does not burn the skin is because of its size. Unlike the cautery tip, which has a tiny area, the return current can be spread over a large broad surface, resulting in less heat. So as long as the pad is in full contact with the skin, the returning electrons will spread over the entire area and a burn can be avoided. But there are risks in areas of high or low resistance. For example, excessive hair, scar tissue, or wet or moist areas should never be used to place a grounding pad. Be sure to shave hair from a grounding pad site. Muscular areas are the best places for the pad, so if it's a choice between the belly and the thigh wins. Last of all, among patients with burns or very small pediatric patients, a grounding pad table is preferred over a regular pad. The next topic we'll cover is tourniquets. There are two types of tourniquets, manual or pneumatic tourniquets, and they can be used for emergency or surgical purposes. Tourniquets work by creating a high pressure zone via tissue compression. The pressure distribution is not uniform. So obviously there is more pressure on the superficial areas as opposed to the deeper areas around the muscle and bone. However, even blood flow within bone channels become impeded with the application of a tourniquet. Manual tourniquets were first employed by the German surgeon Johann von Esmark and initially used leather before switching to rubber in the 1870s. The problem with manual tourniquets is that the pressure is not consistent and changes with movement of the limbs. The problem with Esmark tourniquets is that there is a high incidence of skin and nerve complications due to shear and migration of the tourniquet. The incidence of nerve injuries with Esmark bandages is reported as high as 3.6% compared to 0.02% with pneumatic modern tourniquets. Pneumatic tourniquets were invented by Cushing, but were not reliable due to over 25% fluctuation in the pressures within the limbs during movements. Eventually, an engineer in 1984 from Vancouver named McKeven solved this problem by computerizing tourniquets to maintain a set pressure, and this helped improve the accuracy to within 90% of the required tourniquet pressure. The main challenge in using a tourniquet is to set the pressure at a level that avoids the development of a venous tourniquet. A venous tourniquet occurs when the pressure is slightly higher than the diastolic pressure, but not high enough above the systolic pressure. As a result, blood flow enters into the limb, but cannot exit. As a result, there is venous pooling and engorgement. This ultimately increases the bleeding within the surgical field. As a result, it is essential that the tourniquet is able to maintain a threshold pressure above the systolic blood pressure. Exsanguination is required prior to the use of a tourniquet to optimize a bloodless surgical field. Remember that antibiotic medications should be given prior to inflation. Also know that wrapping allows for faster exsanguination than limb elevation. However, the results are similar after approximately 3 minutes of limb elevation. So what are the benefits and risks of tourniquet use? In addition to allowing for a bloodless field and providing anatomical visualization, tourniquets can also provide anesthetic benefits, as in a beer block. There is also some evidence that operating time is reduced, but this remains controversial. So far, studies comparing the use of tourniquets with ankle fractures, knee arthroscopy, knee arthroplasty, and several upper limb procedures have not been able to confidently show any significant reduction in terms of operating time or blood loss. In fact, when considering the reported local and systemic complications that can arise from the use of tourniquets, as seen in the following table, their use becomes of questionable value. We'll go through some of these more common complications in the next few slides. The most commonly reported complication of tourniquet use is actually nerve injury, which is reported to occur in about 1 in 1,000 cases with a pneumatic tourniquet and about 3% of cases with an Esmark use. It is likely a result of mechanical compression in addition to the ischemia. Up to 2/3 of patients demonstrate some degree of EMG changes just after 1 hour of application of a tourniquet. A well-documented but little-known complication of tourniquet use is the post-tourniquet pain syndrome. This is reported to occur in up to 2/3 of patients after 1 hour of tourniquet use. There is both an acute and chronic post-tourniquet pain syndrome, the difference being that the acute type symptoms last less than 6 weeks, and the pain is the most common complaint. On the other hand, in the chronic type, symptoms last more than 6 weeks, and swelling is the most common complaint, followed by pain. The chronic type, however, is felt to be more similar in pathophysiology to reflex sympathetic dystrophy. Padding is recommended underneath the tourniquets to minimize movement and skin injuries. However, the padding should be applied uniformly. In the above example, a piece of iodine-soaked gauze was placed underneath the tourniquet to protect a wounded area of skin with abrasions. After the tourniquet was removed, you can see that the pressure ulcerization that it had caused just by increased pressure on that area. So what about the risk of DVTs, especially considering the obstruction to venous flow? Well, tourniquet use undoubtedly increases the formation of blood clots, but not at a clinically relevant level. Likewise, echocardiogram studies have also shown that pulmonary embolisms occur during both inflation and deflation, but most commonly about 1 minute after deflation, and the quantity of embolisms increase with tourniquet time. More importantly, the use and release of tourniquets when the tibia is being reamed is reported to increase the risk of fat emboli and pulmonary embolisms. As a result, it is always recommended to deflate a tourniquet prior to reaming. Tourniquets also have cardiovascular effects. The simple application and inflation of a tourniquet reflexively raises blood pressure, albeit mostly in patients under general anesthesia. There are reports of cardiac arrest or failure within seconds of inflation, and this is felt to be due to reflex hypertension, as well as sequestration of blood volume. In patients who have cardiac disease and are volume dependent, keep in mind that the inflation of a tourniquet can sequester up to 7 to 8% of their blood volume. For this reason, one should never inflate two tourniquets at the same time, because it simulates a type 1 hypovolemic shock, where there is approximately up to 15% loss in blood volume. Of note, there is no evidence that slow inflation or slow deflation provides any benefit. So in terms of tourniquet use, there's only one absolute contraindication, and that it should never be used on a limb with a vascular graft or fistula. Other relative contraindications are in patients with a history of vasculopathy, like peripheral vascular disease, Raynaud's, or DVT. Likewise, any traumatized limb with a vascular injury is a relative contraindication for tourniquet use. Lastly, tourniquets are relatively contraindicated among certain patient populations with poor cardiac reserves or sickle cell disease. Also, they should not be used on limbs with severe infections due to the potential to spread or septic emboli. So what pressure should a tourniquet be set at? Well, there are no clear guidelines, except for the Association of Surgical Technologists and Operating Nurses. In general, upper limb surgeries are set at 200 mm mercury, while lower limb at 250. With pediatric patients, simply add 50 mm mercury to their systolic blood pressure reading. A more precise recommendation from the Association of Operating Room Nurses is to have gradually increasing settings added to the patient's resting systolic blood pressure. In either case, the maximum pressure should not exceed 250 for the upper limbs or 300 for the lower limbs. In terms of tourniquet duration, there is ample physiologic evidence to show that muscle tissue becomes irreversibly injured after 1.5 to 2 hours of use, and it requires up to 45 minutes of oxidation to return back to its normal metabolic state. In regards to nerve tissue, injuries begin to increase threefold after 30 minutes of tourniquet use. Therefore, it is recommended that for every 2 hours of tourniquet use, a breather period of at least 15 to 30 minutes is provided. Some facilities also have an assortment of cuffs. Conical cuffs are ideal for obese and muscular patients with large conical thighs and are more effective than regular cuffs. Also, wider cuffs distribute the forces more evenly and are preferred. The general recommendation is that a tourniquet should cover over 1/3 but less than half of a limb section, like the arm or the thigh. You can see from the lower graph that a wider cuff can include pulse pressures at a lower pressure than a narrow cuff. The upper graph also shows that a conical cuff can include pressures more effectively at a lower tourniquet pressure than a standard cuff. There are some other considerations to be aware of. First, be sure to place the tourniquet at least 3 centimeters away from bony prominences like the malleoli or the fibular head to avoid injuries. Also, be sure to place padding underneath the tourniquet with no wrinkles or moisture. There should also be a minimum of 7 centimeters, in other words 4 fingers of overlap, but not more than 15 centimeters when placing the tourniquet. This concludes part 2. Next we'll move on to the last section.